Hi everyone, my name is Dominique Jacobs and I am a third-year medical student at PCOM. Today we will be discussing widespread morphea development following pembrolizumab therapy. So this was a 64-year-old Caucasian male who presented to the office with the chief complaint of skin lesions located on the anterior and posterior trunk. The lesions were described as painful and itchy and were present for over 1 month. The patient had recurrent squamous cell carcinoma of the throat and was undergoing therapy with pembrolizumab, initiated more than 1 year prior to presentation. A punch biopsy was performed, and topical therapy with betamethasone was initiated. The patient was counseled on the nature of morphea and the likelihood of this relating to the patient's immunotherapy. Unfortunately, the patient was lost to follow-up. Morphea is an acquired sclerotic disorder that in most cases is limited to cutaneous and subcutaneous involvement. Historically, it was called localized scleroderma, sclero meaning hardening, derma meaning skin. There's much that's unknown about the etiology, but it's believed that both an underlying predisposition and an environmental trigger are needed. So trauma, medications, infections can sort of instigate morphea. Also, there is a little bit of an autoimmune connection as well. I think about 40% of patients have a positive ANA. So there are case reports of various medications linked to inducing morphea. What I found were 5 cases linked to PD-1 inhibitors, pembrolizumab. However, most of these patients were melanoma patients. So this is actually one of the first patients we found with squamous cell carcinoma who was taking pembrolizumab that ended up getting morphea. A PD-1 receptor is a checkpoint inhibitor that downregulates cytotoxic T-cell response. So if you inhibit the inhibitor, you end up getting an anti-tumor response. So these cytotoxic T cells become reactive and they do their job, basically. So with pembrolizumab, because of this reactive response, skin reactions are very common side effects. And the ones that are most common are rashes and vitiligo. Morphea has been seen clearly with the melanoma patients, but not as common. So it's characterized by thickening of the skin, resulting in the deposition of collagen-rich extracellular matrix. The lesions are described as oval erythematous to violaceous plaques, and they resolve into this sclerotic hairless plaque with various amounts of post-inflammatory hyperpigmentation, which is what you see in these photos. Just so you know as well, the white circle you see on the photo, that's a comedonicus, a nevus comedonicus, which is just a pale-colored patch composed of dilated follicles. It has nothing to do with the pembrolizumab. It just, this patient happens to have a certain type of mole, basically. So morphea, the diagnosis is typically made clinically. However, biopsies should be used to exclude other competing diagnoses, such as sarcoid, paniculitis, mycosis fungoides, radiation, dermatitis, and vitiligo. Treatment is guided by the depth of involvement and the extent of the lesions, and basically how much they bug the patient. So topicals, you could do topical steroids, which this patient tried, or tacrolimus. Other treatments, you can do intralesional steroid injections, phototherapy with UVB or UVA1. If severe, you could do methotrexate, or systemic steroids could be considered as well if the lesions are painful and bothering the patient. These lesions will over time subside. They can recur as well. And I think it's important to make note that localized scleroderma does not turn into systemic sclerosis. Yes, by biopsy they are identical. However, they are 2 different cutaneous manifestations. So a way you could tell them apart is by asking about the patient's history, such as do they get a change in color in their fingers when they go into a cold environment, for example, which would be Raynaud's, and that would hint towards systemic sclerosis. So in conclusion, these immune checkpoint inhibitors, they're used to treat various malignancies, and it's likely that further new cases of similar sclerodermoid cutaneous side effects will be expected. And right now, there's no established standard approach to therapy in these instances. So further studies are needed to investigate the susceptibility of patients to sclerotic diseases following pembrolizumab treatment. And this is important in order to more accurately educate patients and physicians about dermatologic adverse events and to discuss possible treatments that one could offer.